Folks, this is crazy. This is a crazy podcast because, I mean, I don't know. I need to pinch myself to see who I have on the screen with me. The Neeraj Agarwal and the Rana McKay to
The Rana
GU.
McKay.
The.
Yeah.
I mean, this is gonna be a lot of fun. Not because we're gonna talk GI, right? We're doing GI today or what?
We can do. Rana can do anything.
Hey, you can do GI. I mean,
MSI high colon cancer. Here you go. No, I'm
yeah,
kidding.
just do IO or something. But we're gonna do GU, but we're gonna make it fun, right? Without music or anything, right? Neeraj, I mean, I think you. By the way, Rana, did you know I used to always call Neeraj, and then I learned, I don't know if you know that the proper pronunciation is Neeraj, and Neeraj. Just so you know,
Shadi,
you call Rana Reina, and it's not Reina. Her pronunciation is Rana. So basically, I'm teaching you both how to pronounce the other person's name.
It is for my American professional world. It's Reina. That's
Don't give them an excuse. They must call you by your real name.
No, but then it gets complicated. It's confusing. It's like, you know.
Oh my God. I mean, I don't know. I mean,
Shadi, I can tell you when I came to US in the University of Iowa, I was telling everybody to say Neeraj, and then it becomes Narij, and then become Garage or whatever. And I frankly, I decided it's not worth my time. And Neeraj is, when Maha called me Neeraj for the first time, like, yeah, this is good. I mean, everybody could say that.
Yeah.
So
unfortunately, Maha is not on Twitter, or I don't think she listens to podcasts.
But people who are Indian, they know exactly what you mean. And if you call Neeraj, I'm like, Reina, I don't want to spend time on this. I got fed up, and I say, you know what? Neeraj is best, rhymes well. And Monty, you, Reina, call me Neeraj. Reina calls me Neeraj too many times.
I call you Neeraj, but I'm gonna call Rana because that's her name. I mean, she may refuse.
She doesn't really. She's not refusing. She's just trying to keep it simple, right?
I think for listeners, they're starting to enjoy this podcast because they thought they're gonna go right away into prostate, bladder, and here we are, just making.
You're recording this or what?
Of course, I'm recording.
No, you cannot.
I am. It is recording. You
have to start from the scratch.
I'm not starting. This is like recorded. The nice thing about Healthcare Unfiltered, Neeraj, is it's completely unfiltered. Like, I don't edit, I don't do anything. Like, everything goes right away on the air. And here we are. We're going to do an introduction, first of all, to the listeners and to the viewers. This is a lot of fun right here. And Rana, do you want to introduce yourself to folks, to the maybe two people who don't know who you are?
Oh my God, I don't know about that. It's you have to disregard the lighting here. I'm not really sure what's going on. The light's
you're
still
good.
out here.
Yeah.
So it's Rana McKay from UCSD. It's a pleasure to be here on with you, Chadi and Neeraj, and really enjoy.
Rana, what's your favorite book in the world?
Toxic Exposure.
Very good answer. Neeraj, do you want to introduce yourself to the one person who probably doesn't know who you are?
Well, my name is Neeraj Agarwal. I'm a GU medical oncologist at the Huntsman Cancer Institute, University of Utah. And before you ask, my favorite book is Toxic Exposure.
I love it. Hey, so a few weeks back, we finished ASCO at the beautiful city of Chicago. And what we thought is we're going to talk a little bit about what's been presented, what's happening in world of GU, because it's gotten pretty complicated. Let's be honest. It's really gotten very complicated. And we thought we'll just pick few abstracts for prostate, few abstracts for urothelial, few abstracts for kidney. What should we start with? Prostate. Let's do prostate. And I'm thinking we should focus a little bit on these, like, that are a little bit more, have clinical implications, a little bit more of changes. And Neeraj, you were obviously one of the stars of the show, I mean, on the podium, and I always love your enthusiasm when you present and you talk. And, the nice thing about your presentation, honestly, is it, like, even if for folks who are listening who may not have kept up to date with all of the trials, you actually give this nice background and a couple of things that, set the level straight. So let's start by a couple of abstracts from GU, prostate cancer, and you pick the first one, Neeraj.
Yeah, so I'll start with one of the most common tests which is used in patients with prostate cancer, which is PSA level, and how it can really help us in decision making, in designing clinical trials, and so on. So I'll pick up two abstracts which were presented by Dr. Praful Ravi from Dana-Farber. So abstract 5002 for our audience who may want to look up after the meeting. And it was led by senior author was Dr. Chris Sweeney, and they used this ICECAP database, so in intermediate endpoints for prostate cancer, and looked at patients who achieve the PSA level, PSA nadir of 0.1 versus who do not achieve a PSA of 0.1 in the context of localized prostate cancer receiving radiation therapy with or without androgen deprivation therapy. So the best part about this study was the magnitude of data set. You're talking about 10,000 plus patients who were treated with, different timeline, of course, but who were treated with radiation therapy plus minus short-term androgen deprivation therapy or long-term androgen deprivation therapy. And I'll come to the bottom line here to make it really time efficient for our listeners. If you achieve a PSA of 0.1 or less, undetectable PSA, you have a much better survival versus if you do not achieve a PSA of 0.1. And it was striking to see that 5-year metastasis-free survival, prostate cancer specific mortality, overall survival, all very nicely correlated with whether you achieved a PSA of 0.1 or not. And most of these patients, even though patients there were some patients like 1/3 patients or quarter of patients only had radiation therapy, but I think these findings mostly apply to radiation therapy with androgen deprivation therapy. And how does it impact our practice? If you don't achieve a PSA of 0.1 within 6 to 7 months of radiation therapy, I think it's time to prepare. You're much more likely to develop metastasis. You're much more likely to have failure of disease progression, failure of therapy, and it requires more closer monitoring, if you will. And also, I think these are the patients who need to be enrolled on clinical trials. So instead of putting all patients on clinical trial, look for patients who did not achieve a PSA of 0.1, which are like 70%, 80% patients. Focus on them so that you can get to the intermediate endpoint of metastasis-free survival earlier. Trial size can be smaller, and you can get to the endpoints faster. On the other side, yeah.
So I was going to ask Rana, basically, this is interesting. There's nothing you're going to do about this today because it's prognostic, but I like the point that Neeraj mentioned clinical trials. So what I'm hearing is that there's 70% of patients who undergo radiotherapy plus ADT who might not achieve that nadir. And those 70%, you might randomize them to intervention versus placebo type of thing, or?
Yeah, I think that this is really provocative because it's thinking about adaptive-based trials and how do you therapy escalate for people that need it? How do you therapy de-escalate for people who don't need it? We've already kind of established the prognostic significance of 6-month PSA for people with MHSPC, and now actually trials are being designed through various entities to look at how do we escalate therapy for those people that don't achieve a undetectable PSA. And you could think of the same sort of strategy in the localized setting. Does everybody need to be given abiraterone a la Stampede for high risk disease, or can there be people who actually can they get by without it? So I think this is provocative. We don't have the answer today, but I think this could potentially be used as a biomarker for selection of unfavorable population for future studies.
Very interesting, Neeraj.
And Shadi, I just want to add another abstract by Susan Halaby. And again, it was led by Chris Sweeney as a senior author from Stopgap M1 analysis. Again, a very similar story. It was in the context of metastatic hormone-sensitive prostate cancer. And this was an older era of trials where patients only received ADT or docetaxel chemotherapy with ADT. And again, very similar theme. Patients who were able to achieve a PSF 0.1 or 0.2 nanogram per ml within 4 to 7 months of starting treatment, they were much less likely to die compared to patients who did not achieve a PSF 4 nanogram per ml. In fact, hazard ratio for death for 0.1 PSA or 0.2 PSA level compared to those who did not achieve a PSA 4 nanogram per ml was 75%. So 0.75. I'm just using the ballpark for the listeners, but 75% are more likely to die if your PSA is more than 4. So again, it tells me that the biology of disease in these patients is quite different, and they need more targeted therapies. They need to be preferentially be put on clinical trials or enrolled on clinical trials. And we see a similar theme. We saw data from Titan trial, data from SWOG 1216 also presented by Mamta Parekh from SWOG, like this is our trial. Again, very similar theme. I think it's time that we design trials for those patients specifically who do not achieve this level of PSA after a certain time point.
That's really, I mean, simple test, significant prognostic value, opens the door for many patients in clinical trials. Two excellent selections in terms of for prostate cancer. Rana, you want to take a stab at another prostate cancer abstract?
Sure.
I can carry on with prostate cancer, and
on.
I thought Rana will be handling the
we'll
kidney
get Rana
and
ready
bladder.
for the kidney, yeah.
Yeah, kidney and bladder. So just because, you know, Rana is after a long clinic day, and that's what we discussed.
She only saw 100 patients. I mean, like
I don't know about that.
You know.
Yeah. So I can go to the biomarkers, right? Homologous recombination repair defects, which was the big story during ASCO. Obviously, multiple trials presented recently. So I'll start with the abstract by Dr. Olmos, David Olmos from Spain, who basically presented the data from hundreds of patients accrued from different clinical trials who were testing for homologous recombination repair mutations. And the bottom line was patients who have BRCA1, BRCA2 mutations and who have like other HRR mutations, and this was in metastatic castrate-resistant prostate cancer. So patients who enrolled on clinical trial and they had BRCA1, BRCA2 mutations and other HRR mutations, their time to progression on first therapy, time to like radiographic progression, overall survival, time to progression on subsequent therapy, all were significantly inferior if they had BRCA1 and BRCA2 mutations. I wish they had also looked at all HRR mutations compared to non-HRR mutations, but I think I'm sure they are working on it. And if they are not, I'm sure Rana will present a abstract in next 6 months on that one. But we are also working on it. So trying to see how these patients, why these patients, or how much aggressive these patients' disease are. And another example from a recently concluded clinical trial, which we just presented in ASCO-2, my colleague and co-chair of the study, Dr. Karim Fizazi, presented the data from TALAPRO-2 trial. This is a phase 3 trial, only in HRR selected patients. So patients who were 400 patients who were biomarker positive in first-line mCRPC, treatment with enzalutamide plus talazoparib, improved radiographic progression-free survival in a dramatic fashion compared to enzalutamide alone. It was a 55% reduction in risk of progression or death. The PSA progression-free survival, so if you look at time to PSA progression, was 11 months in the enzalutamide arm and 28 months in the combination arm. So 17-month delay in PSA progression on treatment with talazoparib plus enzalutamide.
That's amazing results.
But
it just makes me ask the question as you respond, Neeraj, and maybe Rana also could comment a little bit. Does this mean every prostate cancer patient today you must know the HRD status?
Yeah,
100%.
Yeah, so I'll come to Rana, but let me just finish that first part. The reason I brought up that example of the control arm survival with enzalutamide, you're looking at 11-month progression-free survival for PSA, 13th-month radiographic progression-free survival. Compare that with the data of Prevail trial, where radiographic or progression-free survival was 21 months with enzalutamide. So what Dr. Olmos and colleagues presented from Spain, and what we also saw exactly very similar picture in the TALAPRO-2 trial, that if you have HRR mutation, especially BRCA1 and BRCA2, your response to standard of care therapy is going to be quite inferior, and you need something more beyond that. So Rana, please go ahead. Sorry to interrupt you on that.
No, I mean, I think that absolutely every single man with prostate cancer with advanced or metastatic disease should undergo germline testing. I think the, magnitude, profound, or propel, I should say, and TALAPRO-2 actually only reinforce that, as opposed to, I think there was a worry that we have done so much hard work to get sort of the community and academia on board with testing, and now we're coming up with all these unselected studies. But I think the data from these studies has only reinforced the need for additional testing for all men with advanced prostate cancer. So I think it's critical, somatic and germline testing.
Neeraj, is there like the ENZA plus PARP inhibitor versus ENZA alone? Why not just do PARP inhibitor alone and forget the ENZA altogether?
That's a fantastic question. And we did a trial. So Maha Hussain led the trial. As you know, Dr. Hussain has led many trials, but this was one of the trials which I like more than many others, because it is going to address one of the burning questions of the field, which is monotherapy with ARPI. Then you combine ARPI with PARP inhibitor, and then you have PARP inhibitor as a third arm, right?
Yeah.
So we are going to show the results. We'll be publishing. Manuscript is being written. The data were presented in ASCO 2022 meeting, but we are hoping I will show you more compelling data. Why combination is more important than either monotherapy alone.
Yep, I look forward to seeing that.
Dramatic improvement in outcomes. With the caveat, another point I'd like to make, 40%, Dan, George, and team has done a fantastic job of working with Flatiron database and showing that 40% patients with metastatic CRPC, or for that matter, metastatic prostate cancer, don't see next line of therapy in the real world. So all of that put together, and the interdependency based on scientific rationale, I think the combination of ARPI plus a PARP inhibitor is going to be the key for patients who are HRR selected in mCRPC setting, and hopefully in mCSPC setting. But to Rena's point, I think testing remains important, even though we are able to show overall survival benefit, a long-term survival benefit, even in unselected patients, because degree of the magnitude of benefit still varies in selected patients versus unselected patients or negative patients. So if patient is negative for HRR mutation, I may have other therapies which are competing.
Yeah.
Versus if they're selected patients, PARP inhibitor-based combination may be the best treatment for them.
Very good point. This is really a good point in terms of the rationale of why you're doing this. So we've gotten 3 abstracts or 4 abstracts for prostate. What else you've got for us?
I don't know how much time we have. I really want to have full, equal, or more time for Rana, because
okay, let's do a couple of kidney. Let's do a couple of kidney ones.
Okay.
And then we'll go back to prostate.
That sounds awesome. Okay, so for kidney.
Yeah.
So it was a really exciting meeting. I have to say, probably the most impactful, maybe this is me being biased, but probably one of the most impactful studies that was presented were the results of the phase 3 CONTACT 3 study. So this was a critically important study. It was presented by Tony Shaweri, LBA, at the meeting with senior author Dr. Powell. This was a study looking at the combination of atezolizumab plus cabozantinib versus cabozantinib alone for people who had progression on a prior immune checkpoint inhibitor. The study was designed for patients with clear cell RCC. What's unique about the study is it actually did enroll patients with non-clear cell histology, specifically papillary, chromophobe, and unclassified. Patients with chromophobe had to have sort of a sarcomatoid component to enroll. And patients need to have had radiographic progression on or after receipt of an immune checkpoint inhibitor, and they could have received that immune checkpoint inhibitor either as adjuvant, first line, or second line, and the immune checkpoint inhibitor was the immediately preceding line of therapy. And, this was a negative study. The primary endpoint was progression-free survival. The curves are completely overlapping. Hazard ratio 1.03, median PFS of 10.6 months in the combination arm compared to 10.8 months in the Cabo arm. And when you look at the subset analyses, subgroups by histology, IMDC, prior lines of therapy, I mean, there was no subgroup that seemed to do better. Interim analysis for overall survival was also, negative. The stratified hazard ratio was 0.94. I think that these data were really quite, it was really excellent to see these data because I know in clinical practice, Dr. David Braun gave an excellent discussion on this abstract. And in clinical practice, he had conducted a very scientific, Twitter poll to kind of get at, what are people actually doing in clinical practice? Probably 30% of people that voted on his little poll, and we sort of have anecdotes of this, like to layer on the TKI after somebody's progressing on their IO. They're on Nivo-Ipi, maybe they're progressing, and they kind of layer on the the TKI onto the IO backbone. And I think what this study showed us is that really there's, at least with a PD-L1 inhibitor, which is atezolizumab, there was really no benefit to that. Now, whether a different PD-L1 inhibitor will perform better, I think is going to be interesting to see. But I think these data were really quite provocative. And I think that, and actually did inform practice as to what not to do. What also was really striking with this data set is it truly captured in the modern era the efficacy of cabozantinib in the second line setting. I mean, this was essentially a trial for IO pretreated individuals. And if we look at the primary PD rate, primary PD with Cabo monotherapy, 5.1% in the refractory setting. I mean, that's tremendous. So I think cabozantinib is really an excellent drug. And, even the PFS data that I shared with you, PFS, again, 10.8 months in the refractory disease setting with a TKI. That's really
so Rana,
really
I like this study a lot. And I was surprised by how effective Cabo was, although again, what you just mentioned. But you just talked about something that a lot of clinicians out there still struggle with. Are all of these PD-1s, PD-L1s interchangeable? And the reason I ask that, because there are situations in other diseases, like in bladder sometimes, or even in other types of cancers, where you see in lung cancer, you see Pembroke has particular activity, but Nivo does not have the same activity. Yeah. And you could blame it on the design of trials and things like that. But I think in this trial, what you can conclude is the addition of atezolizumab to cabozantinib is not needed, for sure does not provide benefit. Can you extrapolate and say adding any type of IO is also unhelpful? Is that enough, you think? We can't obviously do studies for every single IO under the sun because there's so many.
No, I completely agree with you. And I don't think that all these PD-1, PD-L1s are created equally. I mean, we already, for one, atezolizumab has no approval at all in kidney cancer. In every single study where atezolizumab was tested in combination in the adjuvant setting, frontline in combination with bevacizumab, and in every setting, atezolizumab has just fallen short of the mark. So I think, I don't think that all these drugs are created equally. I do think the PD-1 inhibitors, mechanistically, they are different than the PD-L1 inhibitors. There is another study being conducted called the TiNivo-2 study that is looking at the combination of nivolumab with tivozanib versus tivozanib alone, answering a very similar question. So I think hopefully we will have some insights from that trial of what is the role of, PD-1 inhibition in, immune checkpoint inhibitor pretreated individuals. But I think these data were quite interesting.
Neeraj, any comment on the contact trial?
I agree with Rana 100%. This was a practice-changing trial for me because it changed my practice. It was common, even NCCN guidelines did not endorse the use of, say, lenvatinib, pembrolizumab, or cabozantinib and nivolumab after disease progression on an IO-based therapy. So what was happening in the community is that pretty much everyone was continuing, not everyone, there's nothing like everyone, there's nothing like 100%, but there were many patients who were continuing IO followed by IO. And think about the cost, think about the side effect burden on the society. And I think atezolizumab obviously may be on the weaker side compared to, say, pembrolizumab or nivolumab, but complete absence. There was not a flicker of benefit with atezolizumab when combined with cabo. I think my practice has changed. I no longer continue IO if I'm switching the TKI or if I'm going from ipi-nivo to cabozantinib. I use cabozantinib alone.
Okay, let's do another kidney.
All right, other kidneys. Let's see. Maybe we can lump together updates on the CLEAR trial and the Keynote 426 trial. So this is the abstract for CLEAR was presented by Dr. Bob Motzer, abstract 4502. And then the abstract for Keynote 426 was presented by Dr. Brian Rini, LBA 4501. And these were updated analyses from 2 landmark IO VEGF studies. So the CLEAR data were the 4-year updates. The Keynote 426 were the 5-year updates. And I think one of the biggest questions, when we have somebody before us with renal cell carcinoma and they're newly diagnosed metastatic disease or kind of have metastatic disease, the big clinical question is, well, do I do IO or do I do IO VEGF? And this is something that we continue to contend with in the clinic. All the data for short-term gains with IO VEGF are excellent. The response rates are higher. The PFS rates are higher. Certainly there's an improvement in OS, but there's always kind of been this questionable about durability with the IO. While the response rates may be a little bit lower and the PFS is a little bit lower, there seems to be kind of a tail on the PFS curve over time that maybe there are people that are deriving long-term benefit. So you're constantly struggling between that long-term and short-term gain. So I think with these data, we saw the final OS get presented for LenPem, the 4-year follow-up data. We see medians being hit with LenPem at 53.7 months, and sunitinib was at 54.3, but I think when you look at the hazard ratio, 0.76, so statistically significant, continued statistically significant improvement over time with longer follow-up of LenPem. I think it was good to see the LenPem data because I think, with the shorter follow-up, the curves were kind of crossing towards the tail of the curve, but there was a lot of censoring that was going on there. So I think, seeing the curves kind of mature over time and kind of demonstrating that continued benefit of LenPem was excellent to see. I think when we look at the, Keynote 426 data, again, now this is 5-year follow-up. We have the longest follow-up for IO, VEGF from 426. There definitely is a consistent benefit over time. The hazard ratio there is 0.84. So definitely continued benefit over time. I think that once we've seen this data, there is still a question of long-term durability. We haven't really seen the, flattening, if you will, of sort of the curve over time. And, I think that, again, in the discussion also by David Braun and kind of discussion in the room, it was a very lively discussion in the room with Mike Atkins coming to the podium and really kind of calling into question sort of the role of IO VEGF in the frontline setting, given the lack of durability. So it was actually a really entertaining meeting. But I think both of these regimens continue to show long-term benefit. I think the question of durability.
But you have to
remains.
choose, right? You have to choose. Like when you have a patient in front of you, you gotta make a choice. Are you able to stratify based on the risk stratification, bone mets? Like what? I mean, how do you make a choice if you have both options available?
Yeah. I think the discussion that I have with my patients is, short-term gain over the potential for long-term gain. Mm-hmm. And there are some people that, don't necessarily have the choice. You need to have a response right away. And I think those are the patients who I select for IO VEGF strategy. Right. And there's probably more similarities than there are differences among the 3 life-prolonging regimens. But another thing that I think David had in his discussion was there was actually a patient survey that was conducted through one of the patient advocacy organizations about what are the goals of treatment for patients in the advanced setting. And the number one thing for many people was potential for cure, long-term durability, long-term, so I think it's important to have that question, because I think right now, the data for Nivo Ipi look really excellent in the long term,
Neeraj, let's do maybe or like maybe a couple of urothelial ones. We don't want to leave urothelial out of the equation.
I don't mind taking a stab at some of the urothelial ones. So we had some really exciting data that were presented on the Norse trial. So there was kind of a focus on FGFR inhibition. FGFR alterations are present in probably around 20% of patients with advanced or metastatic UC, though I think, I know that's the number that's sort of put out there. I think in clinical practice, I know in my practice, I don't have 20% that have FGFR alterations, though I know that number is always kind of quoted. And so there was a study that was conducted. The Norse trial was a phase 2 study enrolling patients with metastatic UC that were ineligible for cisplatin-based chemotherapy, that had select FGFR alterations, mutations, or fusions. This was a frontline trial of patients not having received any prior systemic therapy, and patients were randomized 1-to-1 to receive erdafitinib. That was initially started at 8 milligrams, and then you can kind of dose titrate up to 9 milligrams, or erdafitinib plus setrilimab. And setrilimab is yet another PD-1 inhibitor. And the primary endpoint of this study was objective response. And we actually saw that, both arms had pretty respectable objective response rates. The objective response rate with monotherapy was 44%. With combination therapy, it was at 54.5%, with an increased number of complete responses that were observed. I think it's, hard to kind of glean regarding which one of the 2 regimens is associated with a better profile. The PFS data looked quite provocative. The PFS data for the combination showed that the PFS was 11 months versus 5.6 months with monotherapy. But again, this was a small phase 2. So I think this data, were important regarding the role of erdafitinib. I think right now it's largely being used in the refractory setting. So this was a frontline study in biomarker selected patients who were ineligible for cisplatin. So
that's interesting. I guess to simplify it to listeners, maybe in frontline metastatic urothelial cancer, has anything changed in your approach to treatment in the frontline setting after ASCO 2023?
So something exciting that has happened, and this is after ESMO 2022, but then data from EV-103 were reinforced at ASCO 2023, is the combination of enfortumab vedotin and pembrolizumab. So we saw for the first time the data, I think they were presented by Jonathan Rosenberg at ESMO this past year. Shilpa Gupta presented data with now nearly 4 years of follow-up from EV-103 from the dose escalation cohort A with EV Pembro. And this regimen is associated with really substantial response rate. Response rate from the study was 33% in the dose escalation cohort. The duration of response was 22.1 months. And now this regimen is FDA approved. It received accelerated approval based on a cohort K analysis from EV-103. So there was updated data that were presented from that study. I think this is going to be a big contender in what happens in the frontline space for metastatic urothelial cancer. I mean, we just saw the data get presented recently also of, gosh, I'm blanking on the trial number, of chemo alone versus chemo plus nivolumab for frontline bladder in cis-eligible individuals. You know, this study was positive. So I think the treatment of frontline bladder cancer is really kind of rapidly evolving, you know.
What are your thoughts about frontline?
Yeah, I agree. I mean, like, Rana, this is once in a lifetime I get to remember something which Rana doesn't, right? So Checkmate 901 trial with cisplatin gemcitabine plus minus nivolumab. We just saw the press release. We don't have the data from the trial yet, but I heard that survival outcomes were quite significantly improved with addition of nivolumab. I think this field is going to be very exciting for us and for our patients, allowing them to receive therapies which are going to keep them alive longer without increasing toxicities.
So that's for the front line. And, you know, you have the combination therapies that we just talked about, various treatments and contenders. We talked about relapse disease. Where does these new therapies in urothelial fit within maintenance treatment that we've talked about previously?
So I think that's a big question regarding maintenance. You know, the the phase 3 study of EV Pembro is, you know, comparing to cisplatin or carboplatin based regimens, but that study has a huge flaw because it does not allow for maintenance immunotherapy.
Right.
And so I think, you know, right now, the current standard of care is chemotherapy and maintenance of avulimab for people who are chemotherapy candidates, whether it be cisplatin or, you know, carboplatin-based treatment followed by avulimab. I think the data for EV Pembro are provocative potentially for your chemo ineligible or cis ineligible patient. And some may argue that a chemo ineligible patient is an EV ineligible patient because some of those side effects can be overlapping with the neuropathy. I think we're going to have to wait and see the data from the Checkmate trial, because on that study, people are getting concurrent IO with chemotherapy, which right now is in the paradigm.
But in essence, if you don't give chemotherapy in the frontline setting today, in 2023, there is no role for maintenance therapy. So if you go with non-chemotherapy first line for whatever reason, there is no maintenance, correct or no?
I guess so, but like if you were to pick EV Pembro, that's going to be just continued EV Pembro until you progress.
Right. So as if you're getting maintenance therapy.
And if you don't pick chemo, then you're kind of if you don't pick EV Pembro, there's a very limited role for IO monotherapy. So then I don't really know what you're picking, you know?
Yeah. Neeraj, do you want to tackle a couple of things in relapsed urothelial? You want to go back to prostate?
We can go to prostate.
Okay.
I mean, there is so much exciting data being presented all over, so we can continue this discussion forever.
I like it.
But I think I would like to just highlight two. Yeah.
Overrated.
Rana saw like 100 patients today, so she needs to sleep more than me.
No, she doesn't. No, she doesn't.
No, it's getting dark. It's so dark in here.
Yeah, that's good. Good lighting.
So I can, you know, talk about two more practice influencing abstracts for our patients. One was presented by Dr. Soon, abstract number 5045. And I have the titles and abstract numbers lined up here, so don't be unduly impressed. And what they did was they compared the lutetium PSMA, so lutetium 177 PSMA's overall survival benefit in therapy trial and vision trial. And this is in the context of lutetium being largely unavailable for majority of patients, our patients, community doctors having to rely on those centers to access nuclear medicine doctors, and all the obstacles they are facing when they want to use lutetium-177. In this context, I think this study is very important. So authors compare the benefit of lutetium-177 compared to the control arm in the therapy trial and the vision trial. Just for a viewer's recollection, therapy trial compared lutetium-177 versus cabazitaxel. In therapy trial, vision trial compared lutetium-177 versus literally a control which was substandard. Half of the patient got only bone strengthening agents, and half of the patients got a novel hormonal therapy after failure on one or even two novel hormonal therapies. So again, nothing to criticize from the trial design perspective, because you're going to doing a phase 3 trial, you cannot really push patients to get chemotherapy in the control arm. You will never accrue on that trial, practically speaking. So I'm just putting the results in the perspective of what is happening in the real world, and that other treatments are also efficacious out there. So interesting result was that the lutetium-177 performed pretty well, very similarly in both trials. But there was no overall survival benefit of lutetium in the smaller therapy trial, where cabazitaxel was the control arm, versus a control without chemotherapy in the vision trial. What is the message for our audience here today? In these highly selected patients who had high PSMA, in the therapy trial, at least there had to be one lesion with a SUV of 20, one measurable disease. And all measurable disease, if I'm remembering well, every measurable disease had to have a PSMA SUV of 10. In this highly selected patient population, where they did not allow any PSMA negative measurable disease and high PSMA disease all over, cabazitaxel performed pretty much as good as lutetium-177 from the overall survival perspective. Although lutetium-177 is associated with better PSA responses and progression-free survival from the other previous results presented from this study. So my lesson from this comparison from these two trials is, first of all, lutetium-177 remains a valuable drug for our patients, but cabazitaxel is also a valuable drug, efficacious drug, and is probably as effective as lutetium-177 in these patients who have high PSMA disease. So we should not forget about cabazitaxel, especially in those settings where lutetium-177 is simply not available.
Well, actually, I wonder if the logistics, and Rana, you can comment on that. I mean, are the logistics much more complex with lutetium in terms of in the community, non-specialized centers, that, you know, this is maybe reassuring for oncologists to use cabazi?
Well, I think cabazi is we can't lose sight of the fact that it's a life-prolonging therapy and is highly effective for patients with, advanced prostate cancer. And I would probably argue that the therapy trial, I mean, the primary endpoint for therapy was a PSMA response. The trial wasn't powered to assess overall survival differences between the two arms. So while there was no difference that was observed, I would say like it wasn't really powered to do that. But cabazitaxel is certainly a highly effective agent compared to vision, where the standard of care, I mean, it was best supportive care. I mean, for some people, they weren't even receiving any effective life-prolonging therapy. But I have to say, I think people are going to figure out lutetium. The community is going to figure out lutetium. There's a huge, not to say incentive, but there's a lot of appetite for getting it set up. There's a lot of desire on part of the patients and on part of the clinicians. Those PSA responses, they're dramatic, they're real. Like it's, there's not a therapy that can cause such a dramatic PSA response like that in the refractory setting, like even with effective chemo that's life prolonging, I think. But, while PSA doesn't really matter, it's not, you're not going to live longer because your PSA drops per se, but there's something very appealing about that.
Hey, sometimes you lived longer with Provenge without even the PSA dropping.
Exactly. There you go.
If you believe the impact
If
trial,
you believe in Provenge. Some people call it voodoo medicine, but you know.
I know. Neeraj, what else?
I think the last one is I always like to talk about our friend's abstract, Dr. Dan George and team from Duke. And this abstract was very relevant in my perspective. 5015, they looked at it was a prospective trial of apalutamide and abiraterone in Black versus white patients with metastatic castrate-resistant prostate cancer. So even though it is a very small study of less than 100 patients, parallel cohort, meaning both patients, whether they were white or Black, they were treated with similar drugs and they were not randomized to each other, but they were just accrued on 2 cohorts. So there are some caveats associated with this trial. But if you look at those 43 Black patients and 50 white patients who both received abiraterone and apalutamide, I was quite surprised to see the preferential benefit seen among Black patients versus white patients. So if you look at 12-month radiographic PFS in the mCRPC setting first line, and these patients had not received these novel hormonal therapies up front, the rates were 79% versus 51%. So 12-month radiographic PFS of almost 80% in Black patients versus 50% in white patients. If you look at no PSA decline, for example, so it's very uncommon to see no PSA decline, but that's really a primary resistant patient population. And it was present in 1% Black patients, but 14% white patients with the same therapy. If you look at PSA decline of less than 0.1 nanogram per, which we just discussed earlier during the podcast, 49% Black patients versus only 28% patients achieved a 0.1, less than 0.1 PSA. So what is the message from this very relevant trial in my view, even though it was a short, small trial looking at a therapy which is not approved by the FDA, that it is time to do trials specifically in Black patients which are using androgen deprivation therapy or deeper androgen blockade as the backbone. I think we just cannot, we have to stratify at least the big trials with Black patients. So race can be a stratification factor in any trial which are using deeper androgen blockade, because I have a feeling that we may see drugs getting approved just for Black patients.
But Neeraj, I mean, you mentioned something important. There are many other big trials. I mean, you've ran a couple of studies that are very large, Rana and others. I mean, where you've used apalutamide and similar agents. Can you go back to these trials and see if you're really witnessing kind of similar observations in the cohort of Black patients in these studies?
I can take that question. Unfortunately, big unfortunately, word is big here. The representation of Black patients is so poor in all industry trials. In fact, SWOG 1216, which was our trial, SWOG trial, we were able to accrue 10% patients who were Black out of total patients. And that we could put in our manuscript, which is coming up very soon, that this trial accrued the highest number of Black patients in the history of all metastatic hormone-sensitive prostate cancer trials. So I think this is time that you stratify by race, at least Black patients versus white patients in all AR signaling inhibitor trials.
And do we know why? Like, I mean, is there a particular, an underlying, mechanism? For example, there's fewer resistant mutations. Like, has anybody looked deeper into why this observation is taking place?
Rana, you want to say that?
I'm not sure we know that. I'm not sure we know the answer to that question. I think that certainly there had been data from Nima Sharifi's lab about D3B1 and what role does that play with regards to the resistance to abiraterone. And there's no data that exists about whether that alteration is less prevalent in African-American individuals, and maybe that's why they have better response. It's hard to really know. I think that we don't unfortunately, you just commented on sort of our lack of African-American individuals in clinical trials. It's quite honestly even worse for genomic databases, and sort of our ability to kind of capture the genomic alterations among ethnically diverse and racially diverse individuals is quite poor. And so, you know, I think that I don't know what the right answer. I think there have certainly been some studies. Actually, NRG has been tremendous in this space. A lot of their trials, they sort of have around, in general, a 20% enrollment of African-American individuals on a lot of NRG localized prostate cancer studies. So, but I think it's work that we need to be doing as a field, and I think work that also we can partner with industry on, because I think that, you know, we need to be able to support these institutions and support the delivery of care in not in less resources area, meaning we need to resource it better.
And fascinating observation. Actually, it begs also the question that some of these trials should open at institutions that serve an underrepresented minorities. And there are certain locations, obviously, in the US where the demographics might help in accruing patients of the Black race into these studies. So we've done a lot of these important ground-breaking prostate. We've done a couple of kidneys, couple of urothelials. Rana, any other kidney or urothelials? Because I know you're getting tired after seeing 150
patients. I mean, this is great. Maybe the one, there's so many great data, but maybe there's one other trial to kind of comment on, which was the 5-year overall survival data from the Vesper trial. This was the trial that looked at dose-dense, perioperative dose-dense MVAC. Early stage. So this perioperative dose-dense MVAC versus cisplatin gemcitabine. And the trial was actually designed during a time when we weren't really giving that much neoadjuvant chemotherapy, and it allowed for the therapy to be given adjuvant or neoadjuvant. But as the trial accrued, actually the bulk of the therapy ended up being given in the neoadjuvant setting. We saw the 3-year PFS data get presented at ESMO in 2021, demonstrating that in the intent to treat pan population, looking at all perioperative strategies, there was no improvement in 3-year PFS. But if you just carved out the people that got the neoadjuvant chemo, there did seem to be an improvement with dose-dense MVAC. And then now we see the overall survival data getting presented that demonstrated in the subset that got neoadjuvant chemotherapy, dose-dense MVAC was associated with superior overall survival. So a 5-year OS of 66% compared to 57%, hazard ratio 0.71. So I think there were, you know, some, not to say issues around this trial, you know, in the way that it was designed. Technically, the primary endpoint was not met, but in this subset of people that received neoadjuvant chemo, there seemed to be a strong benefit to dose-dense MVAC. So I think that potentially with this data, there may be a predilection to want to give dose-dense MVAC in the neoadjuvant setting for people who are chemotherapy candidates and cisplatin candidates. But that's probably the last trial to potentially end with, given that it was a.
This is really interesting, though, because I bet you that a lot of community oncologists might actually view GC as much easier to give than dose-dense.
Oh yeah, hands down.
No, but I mean, I think it has practical implications. I mean, Neeraj, would you agree that, like, would that be, if a community oncologist calls you for a question, would you say use dose-dense MVAC?
Yeah, I've rarely seen our community colleagues using dose-dense MVAC. Rarely. It's all GemCis, even though we have always believed that for neoadjuvant chemotherapy, it should be dose-dense MVAC. So I think these data will really help. Very pertinent data.
Yeah.
Well, great.
Anything else? I know we're at the top of the hour. This is probably the most effective hour we've done. Like, we've done 4 or 5 prostate abstracts. We've done 3 urothelial, a couple of kidneys. I feel like we talked about early stage. We talked about early stage urothelial and kidney cancer. Maybe anything in kidney cancer in the adjuvant setting, Rana?
Yeah, actually, we can updated data from Checkmate 914 were presented by Bob Motzer. And so this study was looking at adjuvant Nivo-IPI in patients that were at high risk of relapse post-nephrectomy. there were two parts to the study. You know, part A looked at nivo/ipi versus placebo. Part B actually had it was a 3-arm randomization, had a nivo arm as well. But the focus here will be on part A, and essentially across all the subgroups, there didn't really seem to be any particular benefit. Now, what was really provocative, I thought, was in the tumors that were PD-L1 positive. There did seem to be a signal that those tumors seemed to derive benefit. The hazard ratio there in that subgroup was 0.4, the confidence interval of 0.19 to 0.84. So, you know, what are we going to do with this data? Unclear. You know, this regimen is not approved in the adjuvant setting. I think there was issues with toxicity in the adjuvant setting. The ipilimumab dosing in this context wasn't what we were traditionally used to in kidney cancer with the 3-week dosing. It was every 6-week dosing, and therapy was given for a 6-month period. But, you know, the only subgroup that potentially seemed to demonstrate any benefit was the PD-L1 positive. And I think it's going to be interesting to see what may evolve from this trial or potentially future trials looking at this specific population.
Should patient get placebo in the adjuvant setting? I thought you're more recommending Pembro after the Pembro in the adjuvant setting, or not really? Is it still placebo an appropriate control arm?
I don't, I think it could be an appropriate control arm, because I don't necessarily think that there's equipoise, or not, I don't think there's indisputable, you know, agreement across the board that Pembro is the standard of care. You know, in this context, I think you'll find that there's kind of some disagreement. We haven't seen overall survival data yet, though the overall survival is looking good. The curves are separating. The data is still immature. So I think we're going to have to see. I think for trial design, I think most studies are being designed with the backbone of Pembro in the control and building upon that. But there's certainly some dispute in the field as to whether every single person should be getting adjuvant Pembro who's got, you know, high risk kidney cancer.
Well, this was my best hour of the day, and I know that it's getting late on the West Coast. It's dark, and Rana had a very, very busy clinic. But despite this, she did appear on Healthcare Unfiltered. And Neeraj, I'm always grateful also for your time. Anything we missed? Any final comments, final thoughts? Anything you'd like to share? I mean, how happy you are being here.
This is great. I couldn't think of a better way to spend my Monday night.
I mean,
hanging out with you guys.
I mean,
I agree with both of you. This can never disagree.
This is airing in August, although we are taping this in July. But we've planned this. We've been planning this for 2 months, and we got it done.
That's awesome.
I think you probably noticed that both of us brought up abstracts which may not have been really discussed, other than the Contact 2 trial and Contact 3 trial and so on. I tried to bring in many of the abstracts which are really practice influencing and should be used for our policy making also, some of them, or trial designs down the line. So hopefully it will be useful to our listeners. Yeah,
it will be. It was really, this was extremely condensed and very helpful, and I think listeners are going to enjoy getting this GU hour. Basically, I mean, what else can they do?
Power hour. There we go.
The power hour of the GU gurus.
Power hour.
Neeraj Agarwal and Rana McKay on Healthcare Unfiltered. I cannot thank you enough. Always wonderful that you gave me time of your busy schedule. Thank you so much.